البث المباشر ابتدى، تفضل.
مرحبا بكم، مساء الخير وشكرا للاستضافة الليلة. أنا دكتورة سوسن عبد الرازق، استشارية الطب الباطني حاليا في أبو ظبي، والليلة إن شاء الله هنتكلم عن موضوع الكوفيد 19 وتحديدا في الهوسبيتالايزد patient أو non critical care patient. So I'm just going to share my screen معاكم. تمام. أوكي. في الساعة القادمة إن شاء الله حنغطي النقاط التالية. إن شاء الله we'll be able to speak about the clinical presentation of the patient. حنتكلم برضو عن the severity of illness والdisposition. We will also talk about the initial assessment للpatient الجاي على المستشفى واللي حيترقد في العنابر. وأخيراً we will talk about the management plan both in terms of the general principles للCOVID-19 وبرضو بالنسبة للCOVID specific therapy. وطبعاً أكيد في الكلام ده هنتكلم عن complications that we hopefully we hope not to see. تمام. I think قبل ما نبدأ أهم حاجة برضو نتكلم عن الحياة اللي ما حنغطيها للأسف. طبعاً قدامنا بس ساعة وفي this is a very broad topic. So unfortunately ما حنغطي الباثوفيزيولوجي، الابيديميولوجي، the prevention، الدايجنوستيك تيستينج. حنتكلم عن الحياة دي يعني صورة يمكن سطحية شوية، لكن أنا شفتها يعني ما شاء الله زملائي في الليكتشرز القبلي غطوا الحاجات دي كلها. برضو ما حنتكلم عن certain patient populations اللي هي pregnant women, children, الناس patients اللي حيخشوا ICU, patients outpatient، ديل كلهم ما حنغطيهم الليلة. Okay, so let's talk about the clinical presentation. طبعا we are all aware of the symptoms حقت COVID-19, لكن I think it's important for us to look at the symptoms that are a little bit more specific لل disease process. This is a study، دي دراسة كانت في أمريكا just published في الشهر اللي فات actually in this month about the prevalence of specific clinical symptoms in the population. As you can see, the population can 1.3 million, so it's a very large study. And not surprisingly, the symptoms, or the majority, I should say that the symptom or the syndrome that was presented most commonly was fever, cough, and shortness of breath. About 70% of the patients came with those three symptoms. الحاجة الثانية المهمة is to realize إنه إحنا طبعاً نتكلم كثير عن موضوع الحمى، وفعلا الحمى دي طبعا من السيمتومز المهمة، لكن the symptom that is most prevalent في COVID-19 patient هو cough. Okay, in fact, as you can see, only about 40% of patients had fever. ومعناتها احنا as دكاترة في المستشفيات لما يجيك المريض with symptoms without fever, definitely this does not rule out موضوع COVID-19. In fact, as you can see, في symptoms كثيرة جدا that are quite common. الهيديك مثلا, you can see myalgias أو muscle pain. دي كلها very common symptoms. Specifically, there are some atypical presentations أو atypical symptoms بيجوا برضو. nausea, vomiting, sore throat. طبعا عدم الإحساس بالطعم أو السمell. دي كلها حاجات برضو بنشوفها في COVID-19 patients. طبعا most recently literature is also showing إنه في dermatologic أو skin manifestations للCOVID-19. anything من الvesicles اللي ممكن تشوفها scattered vesicles, macular papular rash, and most recently sort of a vesicular rash that is seen on the toes or the extremities. Conjunctivitis is also a possibility. Atypical symptoms دي بنشوفها أكتر في patients immunosuppressed أو older patients. So لو جاك patient with مثلا fatigue أو mental status change وشوية nausea، برضو you must consider في البانديميك ده إنه احتمال يكون COVID-19. طبعا بالنسبة لكم في السودان you have an additional challenge اللي هو طبعا موضوع endemic diseases اللي ممكن to present بsymptomology very 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 similar للCOVID-19 اللي هو طبعا الفيفرز والميالجاز والحاجات دي. طبعا in that case you will go through البروتوكول بتاعكم اللي هو انتوا بتعرفوه كويس جدا جدا بالنسبة لل-endemic diseases. طبعا unfortunately there are patients that present لما يكون وصلوا مرحلة متقدمة من المرض، وللأسف they will present with issues like pulmonary embolus, acute coronary syndromes, stroke and delirium. أنا أخذت الحاجات دي هنا ليه؟ عشان مرات this patient will present بس بالحاجات دي. So you have to think هسه في أيام البانديميك إنه احتمال يكون في underlying COVID-19 وأي زول بيجيك BPE أو acute coronary syndrome أو stroke or any other sort of acute manifestation should be ruled out لموضوع COVID-19. He should be screened, he or she should be screened. تمام. بالنسبة للseverity of illness طبعاً there are multiple classification systems في العالم. أنا اللي حركز على ال World Health Organization classification system. And as you can see, إحنا they are defining 4 levels. أول level هو المايلد اللي هم الناس اللي عندهم أعراض لكن ما عندهم أي evidence of pneumonia or low oxygen. كويس؟ ديل يعتبروا mild. Most of the time mild symptoms ديل can be treated برا المستشفى وممكن نتكلم عن حاجات دي in a little bit. The next classification هو moderate symptoms اللي هو symptoms plus signs of mild أو early pneumonia لكن the patient is not hypoxic وما عنده أي ضيق في النفس. ودي طبعاً this is a group where الترياجين بتاعك كدكتورة أو بتاعتك كدكتورة هتكون مهمة جداً جداً بالنسبة لل overall outcome للpatient. بالنسبة للسevere ديل اللي بيجوا بالsymptoms اللي احنا تكلمنا عنها plus significant hypoxia defined as oxygen saturation less than 90% on room air أو significant tachypnea or respiratory distress. ديل طبعاً considered severe والترياج هناك بيكون واضح جداً. طبعاً ديل حيخشوا at least العنبر ويمكن كمان يحتاجوا العناية المركزة. آخر كلاس هو البيشنت اللي بيجيك in critical condition اللي هم الناس acute respiratory distress syndrome أو in sepsis. ديل طبعاً they will go straight to the ICU. طيب طبعاً إحنا we have seen the studies in the last several months. في الشهور اللي فاتت دي عرفنا إنه the majority إحنا بنقول always the majority of patients come with mild symptoms. This is a study من ووهان ومن الستاديز الأولى يعني اللي بيّنت إنه basically 80% about 80% of infected individuals at that time هم طبعاً الستادي دي كانت على فوق 70,000 مريض. So it was a very big study. Well, basically it showed إنه في the majority of cases people have mild symptoms that we described in the last slide. The next level طبعاً is severe symptomology was about 15% of patients and then the critical patients were only 5% من الناس infected. دي طبعاً this is very reassuring وأي حاجة لكن أفتكر again when we're thinking of the hospitalized patients actually الريشيوز دي بتتغير. طبعاً الزول اللي بيجيك المستشفى أكيد حيكون أصلاً في مراحل متقدمة أكثر من ال general population اللي هم they surveilled يعني. طيب بالنسبة للhospitalized patient this is a nice study طلعت الشهر اللي فات من نيويورك سيتي طبعاً اللي هم كانوا as you all know يعني having a very high level of transmission وعرفوا إنه اللي بيجوك المستشفى only 50% are mild كويس 40% are severe و14 أو 15% يعني بيكونوا محتاجين عناية مركزة. أنا بعتقد بالنسبة للسودان احتمال كمان النمبرز دي كمان تكون even more severe as طبعاً الناس اللي بيوصلوا في المستشفى بيكونوا طبعاً يمكن في مراحل أبعد basically because of course a lack of resources أو a lack of ability to get to a hospital يعني. تمام. Okay, so احنا تكلمنا هسي عن ال severity of the illness وال distribution حق ال severity ده. هسي حنتكلم في موضوع ال risk factors. طبعاً ال risk factors one of the major risk factors اللي عرفناها عن ال COVID-19 هو age. Okay, طبعاً there is no real cutoff. ال cutoff احنا بنقول 65 لكن definitely as you get older generally your likelihood of needing hospitalization is higher. كويس and your likelihood of having severe disease is higher طبعا. برضو عرفنا إنه الريسك بيعلى مع ال pre-existing conditions ال chronic diseases specifically pulmonary disease طبعا kidney disease, diabetes, hypertension, heart disease, whether it's coronary artery disease or congestive heart failure. Obesity, very important. And then, of course, any level of immunocompromise, whether it's HIV or medication-induced immunocompromise. الناس دي, they have a higher risk of having severe disease. If we look at specific studies, again, طلعت في الموضوع ده. I'm using هنا, this is a study by the CDC looking at surveillance data في أمريكا. هتلقوا إنه مع كل يعني مع كل 10 سنين في العمر، كل ما الواحد يزيد في عمره كل ما بيحتاج المستشفى للعلاج للكوفيد 19. So this was a study looking at المرضى hospitalized في أمريكا across 14 ولاية والنسبة بتاعة الhospitalization. As you can see فوق ال 65 you will need to be hospitalized يمكن 4 times as likely to be hospitalized as زول تحت ال 50. دي حاجة مهمة جدا and again it goes to the risk factor حق ال age. It's a very big risk factor we have to keep in mind. بالنسبة لل underlying conditions اتكلمنا عنها لكن important نفس ال population ديل they looked at the overall prevalence حق ال underlying conditions and you can see about 89% أو 90% من ال hospitalized patients بالكوفيد كان عندهم underlying condition 90%. This is طبعا very 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 significant. The most common underlying condition was overall هو ال hypertension. Right? And it's most likely because it's the most prevalent disease as well, one of the most prevalent diseases. لكن كنت عايزة برضو بس يعني to stress point واحد هنا إنه ال obesity كان the second most common underlying issue or disease في أمريكا. So obesity is really a significant risk factor. وactually في الناس اللي تحت ال 50 ال obesity risk factor أعلى من ال hypertension. And what do I mean? Risk factor for requiring hospitalization. الليلة إحنا كلامنا كله عن ال hospitalized patient. So الحاجة دي طبعا مهمة to keep in mind. طيب إحنا كده راجعنا العوامل الأساسية اللي هو الدكتور في المستشفى لازم بالذات as he triages the patient to consider لما يقرر أساساً البيشنت ده مقر العلاج بيكون وين. Okay? Why is this important? Because we know في COVID-19 and this is across the world وأعتقد في السودان بيكون طبعاً a very important issue اللي هو ensuring the resources الموجودة to be used appropriately. يعني ما أي زول بالCovid-19 may require hospitalization. طيب عموماً الثلاث عوامل دي مهمة جداً ال severity of illness, the risk factor وال social factors اللي هي we did not talk about لسه لكن دي من العوامل الأساسية when you make your decision as to الزول الجايك with suspected أو confirmed COVID-19 where should he be monitored and treated. عموماً ال patient mild severity of illness is mild اللي هو if you remember it was basically the patient اللي عنده symptoms لكن not hypoxic. That patient can generally be treated outside of the hospital. وأنا هقول outside the hospital because it depends on the social situation. A mild disease, again, assuming again low risk factors, you can consider this patient to be treated برا المستشفى. يعني يا في البيت إذا عنده إمكانيات العزل التام طبعاً في البيت so that you can decrease the risk of transmission أو إذا ما عنده other people في البيت معه ساكنين معه that are high risk. This type of person ممكن تقول له go للبيت isolate yourself وتديه طبعاً instructions حقت isolation and essentially isolate for 14 days وتديه طبعاً very important patient education معلومات للأعراض أو الحاجات اللي ممكن تخليه يرجع للمستشفى عشان كمان ما يهمل إذا في تغيير في الستاتس أو الكونديشن. إذا ما يقدر يعزل نفسه في البيت أو عنده high risk individual معه في البيت، يبقى isolation centers أو community facilities الموجودة حقت isolation في دول كثيرة فتحت centers بس للعزل، يعني ما عندهم إمكانيات كثيرة طبية، و basically they are there just monitoring the patient in terms of isolation بس. Usually الفاسيلتيز دي ما عندها أكسجين، ما عندها أي حاجة. may even be في دول they used داخليات الجامعات أو هوتيلات، المهم لكن it is an isolation facility وفي ناس monitoring إنه الزول ده فعلا بيعزل بالطريقة الصح. طيب ده بالنسبة لل low severity of illness, low risk factors. البيشنت اللي بيجيك with moderate risk factors ده البيشنت that you really moderate illness severity but risk factors بتكون مهمة جدا for you to make the final decision. Obviously is a high risk factor، يعني ده البيشنت اللي جاك بأعراض plus maybe early signs of pneumonia لكن ما في hypoxia، ده المودريت صح؟ So in moderates they have a risk of طبعا progressing. Everyone has the risk to progress، لكن الزول اللي عنده high risk factors بالذات diabetics, hypertensives, obese they have a higher risk and most of those we keep في المستشفى. كويس؟ إلا إذا again severity of illness is moderate, risk factors are low and the social conditions are okay، ممكن برضو to consider إنه الزول ده يعزل في البيت وتديه الانستركشنز. طبعا اللي بيجيك بالسيفير ديزيز ما فيه كلام، الزول ده بخش المستشفى at least العنابر إذا ما احتاج ال ICU. أوكي طيب حسي we're في المرحلة اللي بعدها اللي هو خلاص قررنا إن البيشنت ده هيخش المستشفى. طبعا أول حاجة وما حتكلم كثير في الحتة دي عشان again دي already غطوها في lectures قبلي، لكن أول حاجة إنه الواحد يفكر في طبعا إذا في any شك إنه الحاجة دي ممكن تكون COVID-19، أول حاجة infection and prevention control measures اللي هي طبعا إنه الزول يشوف المريض في isolated area، ممكن يكون كمان بعيد من المستشفى أو برا المستشفى في خيمة أو تنت أو facility يعني معمولة متخصصة للسكرينينج والترياج. وطبعا بخط الماسك على البيشنت، you make sure انت ذاتك لابس the appropriate PPE، ودي طبعا من step 1 يعني بالنسبة لل initial assessment. step 2 طبعا هو الفيزيكال اكزام طبعا vital sign يعني checking. طبعا في الفيزيكال اكزام you are going to focus تحديدا في vitals. You're going to make sure check if there's hypoxia, any fever, any hypotension, tachycardia، الحاجات دي كلها مهمة طبعا. You will look at the respiratory rate and the work of breathing to see if he's using accessory muscles، إذا عنده any type of respiratory distress، دي حاجة مهمة جدا. بعد كده you will do a focused exam, the cardiovascular exam, the lung exam, and of course the neurologic exam, because again we know that alterations in mental status or signs of other neurovascular disease could be part of COVID-19. So دي أول حاجة. طبعا you will put him on him or her patient على المونيتور وهتحط pulse oximeter to check the oxygen levels. By this time you should have a good sense البيشنت ده هل هيحتاج عنابر يعني عنبر عادي حق طبعا isolation عنبر للكوفيد-19 أو يحتاج عناية مركزة. So a diagnostic test, let's assume إنه زول ده is not critical condition and can go to an isolation floor أو isolation ward للكوفيد-19. التستنج الدايجنوستيك تيستنج طبعا هتعمل الكوفيد-19 تيست اللي هو النيزوفارنجيال reverse transcription PCR test. دي طبعا ما هتكلم فيها كثير برضو already اتغطت قبل كده، لكن this is the preferred method for diagnosis. بعد كده you will order some lab tests. CBC طبعا you will focus, as you know we see موضوع you look at the total lymphocyte count because lymphopenia is one of the common يعني laboratory signs of COVID-19. You'll also look at طبعا whether there's underlying anemia and whether there's any thrombocytopenia وكده. الميتابوليك panel مهم جدا طبعا. As you know COVID-19 may cause a transaminitis أو an elevation in the liver enzymes, ال ALT وال AST. The kidney function, again, COVID-19 may cause a decrease in kidney function. So you will check that. وطبعا ده كله برضه بوريك إذا في any other chronic conditions. من الحاجات المهمة طبعا is to check what we call inflammatory markers اللي هم الكرياتين kinase, ال C-reactive protein, ferritin, ال coagulation panel. دي مهمة جدا because we're going to talk بعد شوية about الموضوع اللي هو الثرومبوتيك أو prothrombotic syndromes اللي بتحصل مع COVID-19. You will check ال D-dimer, again an inflammatory marker وبرضو a marker of طبعا coagulopathy. ال LDH and the troponin. والفكرة إنه as we many of you may know, there have been reports and there is we know that COVID-19 may also affect the heart. هنتكلم بعد شوية how it may affect the heart. لكن you will check a troponin to see whether or not there is any cardiac involvement. من التست اللي حتطلبها هو ال EKG. Again, looking specifically إذا في any markers of cardiac disease involvement in COVID-19. طبعا في ناس ممكن يجوك ال COVID-19 can cause an issue such as an acute coronary syndrome طبعا وكده. This will be showing طبعا في ال EKG. We used to look very much at في ال EKG we focus on موضوع ال intervals وال QT بالذات the QT interval because we used to start QT prolonging drugs. We have stopped that وحنتكلم بعد شوية لكن nonetheless ال EKG ده من أهم ال diagnostic tests اللي لازم to order it لما تشوف patient في COVID-19 في المستشفى. وطبعا a chest X-ray at the least. In fact, if the patient is not, to be quite frank, chest X-ray is a good test إنك تبدأ به. وطبعا a chest X-ray حوريك إذا في any pulmonary involvement, i.e. if there's any COVID-19 pneumonia. If I know there are some centers around the world, China, for example, really used chest CT. Like this is unnecessary and not recommended إلا إذا it will change the management حقك. لكن usually the chest X-ray is enough. The reason why the chest CT is not recommended طبعا cost effectiveness والحاجات دي. لكن remember إنك لما ترسل زول for a CT scan أنت كده بتعرض الستاف حق ال CT والtransport staff والمستشفى كلها على potential transmission. So a chest X-ray, as you know, can be done إذا في إمكانية to have a portable chest X-ray بيكون أحسن. If not, at least you're limiting it just to the chest X-ray. طيب الحاجات الثانية اللي إحنا we check routinely بالذات إذا ما بنعرف البيشنت أو أول مرة نشوفه we make sure إنه we get hepatitis B and C serologies عشان إذا شفنا transaminitis أو حاجة في الليفر بنكون عارفين إنه there's no underlying secondary viral issue. We test for HIV again to look at whether or not there's immune compromise. وبعدين if you suspect إنه في secondary bacterial infection عشان في patients the story though has to be consistent. يعني إذا الصورة جات إذا أنت شكيت إنه ممكن يكون في secondary bacterial infection then you should check blood cultures. لكن it's not required. والقصة بتاعت ال secondary infection usually the story is the patient كان مثلا عنده أعراض الكوفيد في الأول بعدين بدأ يتحسن ومع الزمن بعد كم يوم يقول بعد أسبوع كده تحسن بعدين بدأ after that week to get a lot worse. Then you may think إنه okay, actually more than a week, let's say 10 days or so. If it gets worse, then you are thinking إنه this may be a secondary bacterial infection. تمام. Okay. So you've ordered the labs دي كلها وبعدين عندنا labs إحنا بنركز فيها شوية because it gives us a sense of the severity of the disease غير السيمتومولوجي اللي إحنا تكلمنا عنها. إذا في ارتفاع في ال inflammatory markers الموجودة هنا ال D-dimer, ال CRP, ال LDH, the ferritin, the CPK, then this gives us a sense إنه this is a more severe disease. That is why it's very important for us to watch these labs. A troponin طبعاً بيوريك إذا في cardiac involvement. Or definitely if you have an extremely low lymphocyte count, again, this is a marker of more severe disease. So حتى لو البيشنت وبتحصل كثير إنه البيشنت بيكون والله أعراضه ما it's okay, it's not bad. He's in the moderate category يعني he's not hypoxic لكن he's high risk وقوم تشوف الحاجات دي. طوالي الحاجة دي is a red flag بالنسبة لنا إنه الزول ده المريض ده بيكون عايز له monitoring شوية extra. تمام. أيوة الحاجة الثانية إنه اللابس دي it tells us إنه المريض ممكن يكون severity أو of the disease may be high لكن it does not prognosticate. ليه حسيه ما عندنا very clear cutoffs. They'll suggested cutoff values لكن it's not clear الفاينل prognosis إذا في direct correlation مع الحاجات دي. It's not clear لسه ما طلعت في الدراسات لكن definitely إذا لقيت patient ب significant ارتفاع في الحاجات دي يبقى you should monitor them for potential worsening disease. Okay. طبعا these findings I'm sure all of you are familiar with لكن we'll review them anyway. هنراجعهم. As you can see on the left is a chest x-ray and you know that a chest x-ray في the COVID-19 patient is characterized primarily by airspace disease, bilateral usually, and peripheral involving the lower lung fields. As you can see here, you have patchy opacities هنا. This is very suggestive of a COVID-19. In this case, the patient also had symptoms that were suggestive of COVID-19. So this is what COVID-19 pneumonia usually looks like on chest X-ray. On the right, you see a CT scan. And again, the classic finding for COVID-19 CT are what we call ground glass infiltrates. As you can see هنا, it looks like a gazaz مطحون or ground glass. Again, he also in this case has a lot of bronchiectasis, as you can see in air bronchograms. So this patient again has a classic CT for COVID-19. طيب, how do we manage? Now we've seen the patient, we put the labs in, we did a chest x-ray, we'll imaging testing, والpatient خلاص خش العنبر. What are the immediate issues that we do to manage the patient? أول حاجة طبعا the most feared complication of COVID-19 is worsening طبعا respiratory symptoms. So دي من الحاجات اللي بنركز فيها. Definitely احنا بنكون عايزين to target an oxygen level around 92 to 95%. And you can do that in many ways. في الأول طبعا you can start with a nasal cannula depending طبعا على how bad oxygenation is to start with يعني. لكن nasal, remember if you start with nasal cannula is really only effective up until 5 liters per minute. بعد كده you can consider a Venturi mask اللي هو can give you 6 to 10 liters of oxygen per minute. Again, if you need to escalate, the final mask really that you can use is the non-rebreather mask. This will give you 10 to 15 liters per minute. عموما, if a patient is on a non-rebreather mask ولسه saturation is below 90%, this is a good indication إنه الزول ده هيحتاج mechanical ventilation or intubation. Now, some centers will allow إنك تجرب حاجة اسمها high flow nasal oxygen أو non-invasive positive pressure ventilation اللي هو CPAP أو BiPAP. لكن again الحاجات دي are temporizing measures. يعني دي الحاجات بناخدها لفترة مؤقتة وبعدين under very close monitoring because this patient already has declared to you إنه هو عيان شديد وإنه هيحتاج most likely some ventilatory support. So إذا خدت CPAP أو BiPAP عليه لازم يكون under a lot of monitoring. Again, you can only use it in patients who are alert, ما عندهم aspiration risk, ما عندهم mental status changes. الناس ديل NIPPV should be avoided if so. Otherwise, if they are alert and okay, you can try it again لفترة مؤقتة. وإذا ما لقيت إنه there is clear improvement كويس. الفكرة طبعا هنا إنك you're trying to delay intubation أو avoid intubation. Very small percentage you can do that. And if you can, تمام, this is تمام جدا, كويس إنك جربته. لكن remember, when you do use these measures, high flow nasal oxygen أو CPAP and BiPAP, you're generating aerosols. So in fact, يعني الفكرة إنه, and this is why a lot of centers who do not really like this, لكن you are generating a lot of aerosols, so you may risk medical staff أكتر. So you really want to do this obviously in a negative pressure room if possible. Otherwise, you will do negative mechanical ventilation for the patient, and they will end up طبعا في الاي سي يو. اوكي دي so احنا اول حاجه بنهتم فيها موضوع الاكسجينيشن. بعد كده عندك symptomatic relief primarily للكوفيد 19. اذا في fever بتديه antipyretics طبعا. You can use acetaminophen, paracetamol, whatever you have يعني. You can give it IV or oral, whichever way. طبعا we like to maintain good fluid status. Euvolemic ما يكون hypervolemic كمان. لكن if you find إنه زول ده dehydrated طبعا ممكن يكونوا dehydrated من عدم الأكل أو من الحمى الشديدة. Definitely give fluids, IV fluid, any type of crystalloid, normal saline أو lactate ringers اللي بيكون متوفر لك. طبعا one of the key issues is we try and prevent thromboembolism. دي حاجة مهمة جدا. ودي حاجة we are finding في الكوفيد 19 again this is new data يعني إنه the rate of thromboembolism is higher in these patients. وحنتكلم عن الموضوع ده in a few slides. أهم شيء ودي الحاجة يمكن مرات it gets overlooked كويس إنه الواحد لازم يركز على المانجمنت of the underlying conditions. إحنا عرفنا إنه معظم patients اللي بيحتاجوا مستشفى عندهم underlying conditions. So الناس ديل definitely manage the diabetes والhypertension والأزمة والحاجات underlying دي as much as you can. This is the mainstay of treatment, managing the underlying disease. كويس؟ In addition to الحاجات اللي تكلمنا عنها. آخر حاجة what I like to call anticipatory monitoring. يعني تكون أنت أيوة متابع أو مراقب المريض بصورة very focused. عارف بالضبط الcomplications اللي إحنا هنكون عايزين نركز عليها ونتأكد إنه we pick it up أو we diagnose it early. وهنتكلم عن بالضبط الحاجات دي شنو next. I also want to talk قبل ما نمشي لموضوع complications. عايزة أتكلم about what not to do. ودي حاجة مهمة because إحنا طبعاً في الكوفيد journey أو الرحلة أو العناية التعرف على المرض ده اتعلمنا حاجات كثيرة جداً جداً في الشهور اللي فاتت. أول حاجة we do not need to start empiric treatment for bacterial pneumonia in these patients. دي أول حاجة. كثير جداً كنا بنبدأ الكوميونتي acquired pneumonia protocol عشان زول بيجي بها fever وكوف وبنقول طيب احتمال يكون برضو بكتيريال خلينا نغطيه وكده. اللي تعلمناه إنه basically most of the time المرضى ديل ما بكون عندهم secondary bacterial infections. بتحصل لكن the majority of the time it does not. So no need to start antibiotics unless فعلا الصورة بالنسبة لك clinical picture looks like a secondary infection. لكن most of the time you don't need to start antibiotics. طيب الحاجة الثانية موضوع الانسيدز اللي هم ناس الابيبروفين والاسبرين وديل. طبعا كان في أول البانديميك كان في small كان في شك و some publicity في موضوع إنه young patients with COVID-19 who receive NSAIDs were doing worse يعني. وده طلع في الآخر the data is not very clear and we do not necessarily have to avoid NSAID. ده موضوع مهم ليه؟ عشان we have patients كتار جدا بيكون already on NSAIDs for other diseases ما مفروض نوقفها وممكن نتابع بالNSAID إذا هو أصلا جاي بالNSAID as his medication regimen. وبرضو مرات بنحتاج to use NSAID actually للفيفر. If الباراسيتامول مثلا ما نزل لك الفيفر you can consider a small dose of NSAID to help in the fever. Try and avoid nebulizers again for the same reason as high flow nasal oxygen تكلمنا عنه. Please try and avoid that again because you aerosolize more of the virus. وآخر حاجة بالنسبة للACE inhibitors ده كان controversy كبير جدا في البداية وعرفنا إنه طبعا الفكرة كانت إنه as we know the COVID-19 virus essentially enters through the ACE2 receptor of the lung وافتكرنا إنه patients on ACE inhibitors may be at higher risk because they have higher levels of ACE2 receptors. طلع إنه الكلام ده ما صح وإنه you should never stop an ACE inhibitor on a patient if he's already on the ACE inhibitor or angiotensin receptor blocker. If the patient is already on this for his hypertension, please do not stop it. You can just continue it. تمام. طيب, we do have some COVID-19 specific therapy that all is investigation. دي حاجة or investigational, حاجة مهمة جدا to focus on. ما عندنا any definitive treatment للCovid-19 ليوم الليلة. There's a lot of work happening طبعا في الموضوع ده, لكن لحسي ما عندنا definitive treatment. أول حاجة طبعا سمعنا بالموضوع الهيدروكسيكلوروكوين والكلوروكوين. الكلام ده طلع كله كلام basically that had no basis in evidence. Several trials have now shown in hydroxychloroquine or chloroquine have not improved, have no patients who took them with COVID-19 had no improvement in mortality or in length of stay or in multiple other indicators. So now we do not use hydroxychloroquine or chloroquine for treating COVID-19. دي حاجة مهمة جدا. وبالعكس, there's 1 or 2 studies that showed إنه احتمال كمان في شوية increase in risk بالنسبة لل QTC prolongation أو ال fatal arrhythmias. So بقينا خالص ما بنستخدمه لا prophylaxis, لا treatment, لا post-exposure prophylaxis. We do not use it at all. طيب, the other drug is a nucleotide analog, remdesivir. يمكن تكونوا سمعتوا بيه. This is a drug that came out in the US. Remdesivir is now slowly being used in some centers. Still, the data is not clear about mortality. لكن there are studies that show that remdesivir has helped in decreasing the length of symptoms in patients with severe disease. So we are using it for those who have severe disease. اللي هم defined as زي ما قلنا في الأول, patients who have symptoms plus signs of hypoxia or respiratory distress. Those patients may benefit from a remdesivir, and not all countries have this. أنا بتخيل يمكن ما بكون موجود في السودان, لكن في أمريكا they are using it in those patients. Again, not because it has a mortality benefit yet, لكن because it does reduce symptomology by about 5 days, which is quite significant. The next thing that we are using around the world is convalescent plasma. بتكونوا سمعتوا بيه. This is basically plasma donations from patients who have recovered from COVID-19. والفكرة طبعا إنه it is antibody rich plasma. We are using it. إحنا هنا غايته في الإمارات we are using it, and we're using it specifically again for severe patients. It is just like a blood transfusion. It's well tolerated. Generally, there isn't a lot of data. It is still considered investigational. And I can say anecdotally from my experience, I'm seeing improvement. Like, and again, this is still under investigation. Like in some centers are using this convalescent plasma. I want to talk about steroids, glucocorticoids, because كان في a lot of controversy بالذات في الأسبوعين اللي فاتوا ديل. إنه there was sort of a press release from an unpublished study from the UK that stated that dexamethasone, was helping COVID-19 patients. Lakin, again, this is unsubstantiated, unpeer-reviewed data yet. So for now, in the US and here, برضو, we are not using glucocorticoids at all for treating COVID-19. We're not sure, again, the data from the previous coronaviruses, SARS and MERS, did not show any improvement for the use of dexamethasone. Now, we will use steroids in critically ill COVID-19 patients, لكن not for the COVID-19 per se يعني. لكن as part of the routine protocol for sepsis or ARDS وكده, طبعا this may be used there. لكن for the hospitalized patient, there is currently no recommendation لا من أمريكا لا من ال WHO to use glucocorticoids unless طبعا something new comes up. As far as I know, the UK, it is approved, and I think they're using it for patients who are in the severe category. آخر حاجة, I'm sorry, الموضوع ده شكله ما طلع واضح في السلايد, لكن one of the other drugs that we are using here is tocilizumab, which is a monoclonal antibody against interleukin-6, اللي هو one of the cytokine mediators that are important in the syndrome of cytokine storm, one of the complications of COVID-19. We are using tocilizumab only in patients with severe disease and elevated inflammatory markers. And NASD, we check on them their IL-6 levels, and if they are elevated and they have an inflammatory picture, ARDS وكده, طوال من يوم, we will start tocilizumab with them. So this is sort of what we have so far. As you can tell, كلها not very conclusive لسه. طيب, we're going to get into موضوع complications. البريد خلاص جاء دخل, you started oxygen therapy وعملت له medical management resuscitation for his volume issues. وبعدين unfortunately over time he developed complications. So yes, the complications can be related primarily. طبعا the complications that we are most concerned about are respiratory complications, and the complication we are most concerned about is acute respiratory distress syndrome. As you know, acute respiratory distress syndrome is not specific to COVID-19. It can happen with multiple different disease processes. As you know, from trauma, you can get it from other bacterial infections, you can get it from pancreatitis, you can get it from transfusion-related lung injury. So there are a lot of different mechanisms that can cause acute respiratory distress syndrome. It is characterized or defined as the rapid onset, and usually within hours of dyspnea, requiring increasing oxygen requirements, and the evidence of bilateral alveolar infiltrates on chest imaging in the absence of طبعا underlying cardiac disease, so that it is not heart failure. We can say this is primarily a pulmonary process. So ARDS is one of the feared complications of COVID-19. Well, generally, what we see is these patients, the rate of progression is interesting. أول حاجة إنه the onset للARDS is slow. يعني البيشنت ممكن يجيك ويقعد معاك ويكون في المستشفى لفترة and looks okay. بعدين it's not until day 6 or 7 actually from onset of symptom that suddenly he or she is getting tachypnic. بيكون شكله هنا طبعا ضيق في النفس وشكله تعبان وكده. لكن once it starts, it progresses very fast. So إذا عندك patient في العنابر وهو كويس وبعدين يوم 6 يوم 7 جاء قال لك يا أخي أنا ما بعرف حاسس بضيق في النفس وكده وعنده وشايف أنت في الانفلامatory markers حقته إنه D dimers are going up, والfibrinogen going up, والCRP going up, والferritin going up, يبقى لازم تفكر في موضوع إنه he is high risk for ARDS. طبعا, as you know, it is ARDS in COVID-19 is essentially profound acute hypoxemic respiratory failure. It is not hypercapnia. This is very rare in COVID-19. It is from the hypoxemia. بعدين usually in COVID-19 ARDS sepsis and shock can occur. طبعا بتحصل عندنا مرضى كتير بالحاجات دي, لكن you can also have isolated ARDS in COVID-19 patients without the shock and the sepsis. This occurs as well. So in either case, طبعا, once the patient is in ARDS, then essentially this is a patient requiring mechanical ventilation and ICU. So دي كلها حاجات مهمة. طيب, طبعا ARDS and the cytokine release syndrome أو cytokine storm are very much related. Basically, الفكرة إنه ARDS is a manifestation of cytokine storm. This is why Azulda is entering ARDS. Basically, cytokine storm is an acute inflammatory syndrome characterized by fever and multi-organ dysfunction. Usually it is due to inflammatory cytokines that are activated, or released, I should say, and essentially cause the activation of the entire immune response, lymphocytes, macrophages, endothelial cells. And as you can see here, there are multiple families involved in this cytokines mediated storm: interferons, interleukins, tumor necrosis factor, colony stimulating factor. The point is, there's this trigger, and suddenly the entire immune system is essentially activated. This causes many different things, including endothelial cell injury, vascular leakage, disseminated intravascular coagulation, or DIC. So unfortunately, it is an unregulated immune response that causes essentially the destruction of tissue and other organs, including the heart, the kidneys, and multiple organs may be involved. So once this storm starts, this is a very, very bad prognostic factor. In fact, the clinical pieces of this is that تلقى patient having high fever, tachycardia, tachypnea, acute neurologic changes or manifestations. وبتلقى again الانفلامatory markers كلها طالعة. عشان كده في الأول كنا بنقول إنه it is very important to check these inflammatory markers and actually follow them during the patient's hospitalization. إحنا طبعاً how often you should follow them has not been determined. Different centers do it differently. Some people do it every 2 days, some people every 3 days. Like, definitely once you see إنه في trend upwards in any of the inflammatory markers that تكلمنا عنهم, you should probably check it daily. Okay, another major complication, ودي حاجات كلها again we are learning over time, هو موضوع ال COVID-19 associated coagulopathy أو CAC. طبعا what we're seeing is in COVID, basically it started off with the observation إنه في COVID-19 patients كتار منهم were developing clots في multiple different areas. Okay, so الجلطات دي كانت بتحصل في الرجلين، في الراس، في القلب. So they were becoming prothrombotic. والفكرة إنه as you know, thrombosis, the underlying pathophysiology is Virchow's triad اللي هو endothelial injury, stasis, and hypercoagulable state. في ال COVID-19 case of بالمناسبة الميكانيزم هنا is not 100% worked out, لكن عارفين إنه there is definitely endothelial cell injury. It can be direct as a result directly من الفيروس نفسه, مثلا in the pulmonary endothelium, and can also be cytokine mediated injury. So this we know is happening for COVID-19. Stasis طبعا, as you know, most patients are hospitalized, are immobilized. So stasis is definitely a feature. But in a hypercoagulable state, it's been interesting. They found there's increased viscosity in patients with COVID-19. And the idea is the viscosity is increasing maybe from the hypergamma globins that are being produced from the cytokine storm. They are also increasing in the production of certain clotting factors like factor 8 and so on. So there is a hypercoagulable state. So all three factors seem to be working for COVID-19, unfortunately, to promote thrombosis. Now, the picture looks very much like DIC, right? اللي هو disseminated intravascular coagulation. So it actually meets criteria if you use the scoring guide like DIC, لكن there are some characteristics that are different about it من ال DIC. أول حاجة إنه COVID-19 coagulopathy tends to be thrombotic, prothrombotic, less bleeding. As you know, with acute DIC, it is yes, في thrombosis, like it is primarily a bleeding diastasis. So this is one of the major distinctions. وبعدين في distinctions, very important ones in the lab work that I'm going to show you here. So let's see if this will work. طيب. أول حاجة الfibrinogen level in COVID-19, just look at these two rows. Please don't worry about all these other coagulopathies. Like, if you look at these two rows, as you can see, the fibrinogen level is actually high in COVID-19. This is very strange. As you know, in DIC, the fibrinogen levels are low because there's a consumption of fibrinogen. So fibrinogen levels are low, maybe normal in DIC, لكن they're never high. So in COVID-19, fibrinogen is classically high. Platelet counts, again, as you know, one of the classic findings in DIC is that you have thrombocytopenia. With COVID-19, you may have a mild thrombocytopenia, lakin you may also have high platelets. This makes it a little different. And then also, as you know, in DIC, you have a prolongation of the PT and the PTT. For COVID-19, most of the time, actually, it's normal. You may have a mild increase in the PTT, lakin it's usually normal. So الحاجات دي should make you think, you know what, يمكن this is, unfortunately, the patient is having COVID-19 associated coagulopathy. What does this mean? You know, they're more likely to thrombose, and most of the thrombosis بيكون في الvenous side. يعني اللي هو venous thromboembolism, deep calf vein thrombosis, as well as pulmonary embolus. And what we found is in the post-mortem, most recently, في data طالعة in the last few weeks, إنه many patients post-mortem are found to have microthrombi in the lungs. There are increasing reports of arterial thrombi. I have to say that, لكن primarily, طبعاً, what has caught people's attention is thrombi in, i.e. strokes in young patients, للأسف. So people under the age of 50 with no underlying comorbidities that after having COVID-19 are then found to have significant stroke. So it seems like there may be some arterial component, but this is much, much lower than the venous component. So what does that mean? That means, again, in all hospitalized patients that need you with COVID-19, the current recommendation, as you can see from this, this is one of the diagnostic management algorithms thrombotic state in COVID-19. As you can see, if the person is not already on an anticoagulant, and they are requiring admission to the hospital, and the person is requiring admission to the hospital here and the regular medical ward, you should give them some anticoagulation prophylactically at least. So low molecular weight heparin is what we usually use, unless there's a contraindication, or if it's not available, you can use also subcutaneous heparin. Lakin the idea is that you really should give them prophylactic anticoagulation. If they're in the ICU, there is no question. They must get at least prophylactic level anticoagulation of fee centers in ICU patients that are giving therapeutic anticoagulation, طبعا assuming ما في contraindications, because the rate in ICU patients of thrombosis is extremely high. In fact, they found even patients on prophylaxis, many of them post-mortem are found to have PEO DVT. So this is what I wanted to say. Please make sure that all patients are on prophylactic anticoagulation who have COVID-19. طيب, we're almost to the end. We're going to cover the heart and the kidney very quickly, and then I will stop for questions. بالنسبة للheart, أول حاجة, you know, most patients who come in, who have heart disease due to the COVID-19, come in with, of course, the COVID-19 symptoms. It's rare in زول with heart condition related to COVID-19 وما يكون عنده any COVID-19 symptoms. Etiology can be multiple. طبعا myocardial injury, وفي coronary mediated and non-coronary mediated myocardial injury like myocarditis, for example. And that طبعا decompensated heart failure can occur, again, just from the fact that this usually, again, this is a patient who has underlying cardiac disease now with COVID-19, BG in decompensated heart failure. وطبعا arrhythmias can occur, but most of those arrhythmias are either you know, sinus tachycardia or atrial fibrillation, atrial flutter, again, related to any infectious process. As you know, many patients may develop these arrhythmias. Now, EKG abnormalities can be anything from طبعا T-wave inversions or depressions, ST segment elevations, depressions, Q waves, depending on the etiology. That's why it's very important to check your EKG when the patient comes in. Generally speaking, we do find it is quite common in تلقى elevation in troponin, especially, remember, most of the patients they أصلاً are older, they have chronic issues, they may have some renal dysfunction أصلاً. So you may find some mild elevation of troponin. لكن إذا في mild elevation of troponin والpatient ما عنده symptoms وما في EKG changes, you can probably just follow it. كويس؟ إذا عندك moderate elevation of troponin, طبعا الtroponin level حيكون على حسب your center and the sensitivity of your assay يعني. لكن if you find إنه في moderate elevation of troponin, you might start thinking, well, could this be, again, with no symptoms طبعا of acute coronary syndrome, could this be stress cardiomyopathy? Is this potentially myocarditis? دي كلها حاجات that you should be thinking about. Definitely إذا لقيت moderate elevations in troponin. طبعا إذا الزول عنده significant elevation وذاته عنده ACS symptoms or chest pain or shortness of breath, heart failure, حاجات دي, then you should really, of course, you will consider إنه this might be a coronary related syndrome and you may take them to cardiac cath. طبعا you follow that protocol بتاعكم. إذا لقيت progressive elevation بعد زي يقول الزول كان كويس وبعد أسبوعين في المستشفى suddenly there's progressive elevation of troponins and with the troponin أنت شايف برضه progressive elevation of a CRP والferritin والfibrinogen والحاجات دي كلها, then this is a good indication that this patient might be in cytokine storm. وزي ما قلنا cytokine storm is an inflammatory process that can attack multiple organs. So this is something, again, to think about. The mainstay of treatment for any cardiac disease related to COVID-19 is supportive care, unless طبعا it's acute coronary syndrome ده عنده pathway براو. لكن you will manage the heart failure, you will give therapy for any of the arrhythmias, you will avoid cardiotoxins. إذا زول عنده myocarditis, that's a tough one طبعا عشان myocarditis, you have to think, are you going to work it up توديه cardiac MRI وحاجات زي دي إذا أصلاً الإمكانيات دي فيه. وصراحة again you have to think of exposure وهل المyocarditis, as you know, ما عندنا definitive treatment أصلاً للmyocarditis. So usually it's supportive care as well. وآخر slide اللي هو الكدني. The kidney is of course برضو affected by COVID-19, and kidney disease can come to you in many forms. It can come as acute kidney injury, hematuria, proteinuria, and it's still, a mechanism is not clear why this happens in COVID-19. Might be from the hemodynamic changes طبعا. The patient might get pre-renal مثلا if they're not eating, drinking, and they have a fever. It might be related to the cytokine release, or there is also consideration it might be viral direct cytotoxicity on the tubular cells of the kidney. So in either case, it is quite prevalent. In some cases, 30 or 40% of patients come in with acute kidney injury with COVID-19. So طبعا you will assess and do the basics. You will do volume assessment, you will do urinalysis. الكدني ultrasound, depending on your center, whether or not you even have أول الإمكانيات. وثانيا if the kidney ultrasound, to be honest with you, is not going to change management much, you don't want to expose your technicians unnecessarily. So it's not required unless you really think there's an obstructive component acute kidney injury not related to COVID-19. Otherwise, you can hold off the ultrasound. بالنسبة للmanagement, طبعا volume optimization. So as a pre-renal, you're going to give fluids. Is a fluid overload because he's in CHF مثلا وديل causing acute kidney injury, you will manage a CHF. طبعا you will avoid nephrotoxic drugs, especially contrast studies, and you will of course exclude any obstructive cause. بالنسبة, unfortunately, some of them do progress. بالذات إذا هم أصلاً عندهم chronic renal insufficiency أو already جايين on dialysis. These patients, if they progress and require dialysis, طبعاً the requirement for dialysis is unchanged. As you know, patients should not be on dialysis unless they have intractable uremia, acidemia, hyperkalemia, fluid overload, الحاجات that require dialysis. And in this case, with COVID-19 patient, we definitely prefer continuous renal replacement therapy instead of intermittent hemodialysis. اللي هو طبعاً patient بيكون on sort of on a dialysis machine over very long periods of time with very, and the idea is that you're limiting an exposure of the dialysis nurse and the dialysis staff. And again, CRRT is done by the bedside. There are different hookups that we are using to again minimize the number of machines that might be contaminated وكده يعني. لكن عموما you will manage this as conservatively as you can, and then require to use dialysis only when needed. Okay, so this is the end of the talk. شكرا لاستماعكم لوقتكم. I really had a fun time. إذا عندكم أي أسئلة، نهى إذا في أي أسئلة لازم بتوريني.
ما في أسئلة دكتورة سوسن. ما في أسئلة دكتورة.
Okay, it looks like there are no questions. Anyway, thank you so much للattention والاستضافة, and I hope you found this helpful. شكرا.